So I believe we are recording, okay? Let's go with that. So I don't even know where I am in this thing, but so thank you for everybody joining today. I am recording it. I think I'm recording it, okay? If not, I'll do it a second time, I guess. But I'm gonna then figure out how to post it. I like to know who's the plant. I love the plant. That's pretty good. It's a pretty plant. I kill all my plants most of the time. Oh, hi, it's you, Brandy. You're the plant girl. That's a very nice plant. All right. Actually, that was Caitlin. You guys are messing with me. All right. So a couple of things I want to say before we get into this, because I did make the PowerPoint and everything, which I will post separately aside from this. So if I totally screw this up, the PowerPoint at least still survives. We're going to do module C will really just be cardiovascular drugs. Okay. And what I'm doing is I'm breaking it into like antihypertensives, diuretic, into smaller chunks so we can get through it. So this morning, this one is just going to be on antihypertensive medications. All right. But before I get on that one, I just want to say, I think there is a chat something or other here that I can put up. And if you guys, near the bottom of your screen for this, there should be an area where you do see chat. Take a look and see if you find it. Because that's how you can type a question if you're still muted while we're doing it. So I can then just immediately get your question, especially if like 4 people ask a question at the same time. Do you see chat, anybody?
Yes.
Okay, so that's where you should be able to type a message, and then that lets me know that you got a question while we're doing this, okay? So I do want to say something about the exam. So I did talk to a couple of people after grades were posted and after I did the little test talk, and there were a couple of questions on a couple of them about other possible answers. So on reviewing it, I did see that there was opportunity to correct, so to speak, some of those options that people did select. So yesterday afternoon, I got into it and I started looking at it, and what I ended up having to do for 6 hours was I did every question on every individual student and went through your answers to be sure that they graded properly. Okay, because part of the way, which is why we don't use Canvas, the course Canvas for the quizzes, because especially, which is awful, for the select all that apply, let's say there's 3 choices, okay? Let's say you pick 2 correct ones and a wrong one. It gives you partial credit for the 2 that were correct, but then it minused for the wrong one. You know what I mean? So it was like you didn't even get really good enough credit for the ones that you did get. So I went in and manually fixed all of them, okay? But what I did notice, because as you guys know, we do, like statistical analysis after an exam and see if it was a good question, a bad question. Amazingly, there was a question that was considered a bad question, so got originally thrown out, so everybody get the 2 points for it. But when I went in individually into everybody's thing, everybody did not answer the same question. A miraculous, amazing, not statistically possible thing by chance that every person, 96 students, all skipped the same question and did not skip any other questions. So the unanswered question was no longer a thrown out question. It was counted as a 0 instead of 2 points. So some of you might have seen your point, you go up and then come back down. When I realized those 2 points in there, we're like, what the heck was that? So it took me a while last night to get over that one because I spent so much time individually looking at that to be fair. And I really don't think that was fair on the other end. And I'm getting all upset about it again. So I'm not going to say anything more. But so your grades may have gone up. Good luck on the next one because they've got anti-cheating stuff all over the place with this electronic stuff on ExamSoft. And we're going to be using it from now on. So yeah, so that's how we're going to go forward. I would say that the question that everybody skipped, something about that topic will be on your final. So you may want to know about that one. So here we go. Let's see if I can do share screen. And then I'm going to pick this. I think it may be working. Did it work? Can you guys see the PowerPoint?
Yes.
All right, thank you. More people joining.
Professor?
Yes, ma'am.
I have one quick question.
Yes.
You said there was a question skip.
Yep. No, everybody did not answer the same question. Just figure it out here. Yep.
There was a question that didn't have any choices. Is that the one you're talking about?
Nope. That one had no choices. That was the INH and B6 deficiency, and I neglected to put selections on there, so everybody did get the 2 points for that one. Now, this was question number 28 that everybody skipped.
How do you skip a question? It won't let you go forward if you don't put an answer.
Not one person answered it.
Really?
Yep. I don't know how to tell you that happened, but everybody did not answer that question.
Was that the blank one?
No, it was not the blank one.
That's weird.
That's weird because it won't even let you go to the next question without putting the choice down. Wow.
Somehow, everybody did not do that one.
Answer every question. I don't know what happened. That is weird.
Yep. Well, anyway, so I'm not going to belabor that much longer, but it was 6 hours. That doesn't count the other couple hours I did last week on it with just using the regular statistical stuff. So this was every individual question for every individual student, like 400 questions I had to go through yesterday. So those are your grades. I hope you guys are happier because it did reflect a little bit better what I would have expected to see for an open book test, a little bit higher grades. And that was like, because it shouldn't be that low of an average grade, you know, they should have been higher. So now they are higher, and I think are more reflective of correct ones. The ones that I did have to just let you know that were the major adjustments from yesterday was for the minocycline, the tetracycline. The staining of the teeth was the major one. However, the other choice was severe birth defects. There is some chance of some skeletal delay in utero. It doesn't really classify as a major birth defect or severe birth defect, but a lot of people did select that. So I gave that points to people whether they chose one or both or either of those. The other one, shucks. I did it so many times yesterday, I can't even think of it. I don't know. I'll think of it again. I'll let you know. But that was the big one that a lot of people ended up getting some points for, as well as, again, in going through those multiple select-alls, or the ones that were select or weren't select, so that they were fairly graded. Okay? Good enough for that? Somebody say yes.
Yes.
Nicole, you know, you're the one I can see mostly here, so rely on you.
Oh, is that why?
Be my person, okay? All right.
Oh my God.
So cardiovascular, we're going to start with just antihypertensives. Now, for you guys, does this, can you see the whole PowerPoint thing screen there?
Uh-huh.
I got to figure out how I adjust it. Oh, I click, okay. So, holy geez, look at those classes of drugs that can work for getting blood pressure down. So remember, how many people do you think have blood pressure, high blood pressure, right? A lot. Practically almost, I don't know, 60, 70% of over 50 or something, you know, like crazy numbers. Although, do know, when people get old, like 80 years old and stuff, everything kind of changes. So a lot of times they don't even need their antihypertensives. They need to start going down. So that is just an interesting thing to know, that if you've got an older person that you're taking care of and their blood pressure ain't that high, take a look. They might be on the same thing they've been on for 20 years if they don't need the same dose or at all. So we're not going to hit every single one of these classes today, as well, because these are broken down into the very individual smaller parts. So, but first, so I'm just going to let you know, these are the ones we're actually going to look at today. Of course, you know, indications, all that stuff. We're going to hit the alpha and beta blockers, the ACE inhibitors, the ARBs, and vasodilators, okay? So first, we're going to go for alpha adrenergic blockers. Yikes, we got to remember all these technical things, right? So, so can you guys not see the end of the PowerPoint slide because of your faces, or can you see the whole slide? You see the whole slide?
I'm gonna like move up the stuff so we can see it.
Let me see. Let me see. I do this. Is that better?
Yeah, you can see the whole slide.
Okay, good. All right, so alpha, they are separated in 1 and 2, of course, just to make it difficult. So we are going to first look at the selective alpha-1 blockers. Now, the way they work, they do dilation, which remember, you get something, you have a bigger vessel, so the pressure will go down. Also, the other thing is that these alpha-1 specifically, they also really work on the prostatic capsule and the neck of the bladder, okay? So of course, as you can see, that would be for BPH. They work really good. They use them for hypertension, but they're not really a first line specifically for hypertension, but I'm going through them in order. Oh, I gotta do this. So those alpha-1 adrenergic blockers, because they block, they're actually an antagonist, BPH. So prazosin, doxazosin, terazosin, Minipress, Cardura, and Hytrin. Those are the brand names. Most of the time you'll see prazosin very commonly for the BPH stuff. Now, what I will say about them, they can be used for other things too. We can even use Minipress with prazosin for nightmares suppression, because you've got to remember adrenergic, you know, that's all those catecholamines, right? These are neurotransmitters that are going to these areas to let them relax. So it just somehow does something weird about nightmares. I don't know how or why. Then alpha-2, they're called centrally acting. Now, they're called centrally acting because they act on the central nervous system, okay? And they are very good for blood pressure, as well as some other things. There's some other drugs that are in this category that are used for other things with sedation and even with some anesthesia stuff that I don't have really included on here. The primary one you'll probably see is clonidine. It is very powerful, very effective. Clonidine comes in a little tiny pill, usually a very small dose, but it also comes in a patch, which is really very nice for people because we like to get things that people can be compliant with, right? Something you take every 6 hours, good luck. But if you just have to put a patch on once a day, life is much better. Now, when I say centrally acting, right? So here's how they work. Central nervous system. You have sympathetic outflow from the central nervous system. And so what does that do? You actually block that. So then you got things heart and peripheral that they are now not getting that stimulation. They're not getting that constriction. Remember that sympathetic nervous system, we're ready for fight. This puts us, or flight. So this actually decreases that. So we actually can decrease our heart rate, vasodilate, even bring down the heart rate. And it does bring down the cardiac output if somebody's like jamming high on that. So that's how centrally actually they act on the central nervous system. So they do not directly act on these peripheral, maybe, you know, like here, blood vessels. It is from the central nervous system, and that is what acts upon the central nervous system, okay? Big warning for this one is first dose orthostatic hypotension that usually results in syncope, which is passing out. So what we do is we try to give people their medication for this, if they're taking it orally, at bedtime. You say, why bedtime? Well, because they're going to go to sleep and not wake up. So that first dose, when that major hit of it first becoming effective on them, they're not getting up. However, if you've got somebody that you're giving it to them and they've got to get up during the middle of the night to go to the bathroom, you really have to watch with them. So that's why you've got to make sure that your teaching for a patient is that if you get up, even during the day, when you're going from lying down, sit up first for a couple seconds, like 30, then stand up. So it's that slow transition of that so that the blood vessels can get some sympathetic stimulation in there to give you that. Otherwise, you just plonk over. Okay. So the other thing is, even if they don't do that, you can see in the middle here, it's dizziness or lightheadedness that people can have, especially if they're on another antihypertensive at the same time. So again, here's some other warnings to know. Because remember, central nervous system, they're depressing that sympathetic nervous system. So you can get a little drowsy, not enough to like fall asleep, pass out or anything, but a little drowsy. You get some dry mouth, but you can get rebound hypertension if suddenly stopped. Now, with clonidine, even if somebody stops it, they can get that rebound hypertension that can last, I think, for like 10 days or something. It's insane. So you don't want anybody to suddenly stop that, because remember, it's from the central nervous system. So it's being blocked, central nervous system being blocked for that sympathetic outflow. You get rid of it, boom, it's like jams all those neurotransmitters, and you clamp down, you have very, very high blood pressure after it. As I mentioned, the patch is great every 7 days. You apply it somewhere on the torso, okay? Some people do on the arm, but back of the shoulder is usually most common. Sometimes you'll find it on the front of the chest, but they need to rotate. It's only every 7 days, hairless, intact skin, okay? You don't want somebody, if they've got like some horrible acne thing going on their shoulder, plop it on there. That's not going to be good. You don't want it where there's an open absorption. You want nice and easy absorption through the intact skin. So again, if you're going to go in and put a patch on somebody, first thing you're going to do is look for the previous patch, get rid of it, then put on the new one. Okay? Never just walk in a room with somebody with a patch and just slap it on. It means you got to look for the other one, because not everybody puts them in the right place. So you got to kind of do a little body check if you don't see one right away. And sometimes people pick them off or they'll fall off, but they have really good adhesive, so they shouldn't just disappear on you. My dog's snoring. Also, like I said, they are used for hypertension. They can be used for migraine headaches, ADHD, Tourette's, even withdrawal symptoms. Again, anything these are decreasing that sympathetic outflow of that fight or flight. And one of the beautiful things is that it decreases hypertension, so we use them for hypertension. Any questions on the alpha blockers? I can't see anybody's face, so I'm going with it. Beta blockers, you guys heard of beta blockers, right? Yes, all right. Again, that word beta blocker, but again, it's adrenergic. And of course, we've got 1 and 2 beta receptors. Again, very easy. Beta 1 is in one place, which is your heart. Beta 2 is in 2 places, which is your heart and your lungs, okay? So beta 1, you'll see these, they are all the alols, or lols for the most part. Their name, metoprolol, low pressure, very good. And there even is as you'll see, the XL. So that's, again, another long-acting one that people can take. You'll mostly see the metoprolol, atenolol for those, but in the very selective ones that are specifically only going to address the heart. The other ones that are non-selective that can also have an impact on the lungs are propranolol and naldolol. All are used for hypertension. Propranolol is also used for a couple other things, even migraine, headache, prophylaxis, and stage fright. Because again, it is blocking some of that adrenergic stimulation. And then there's 2 other ones that actually have some combination of both alpha and beta, and that's carvedilol or Coreg. That one you'll probably see a whole bunch if you work in a cardiology area. So that's a very common one to see a lot. And labetalol, that's been around for a long time, and the brand name is Trandate. So let's see how they actually work. So when we give somebody beta blockers and we are trying to control them, we call it beta blockade. Because this is where we are really trying to address the heart, because not only for hypertension, but beta blockers are used a lot, which we'll talk more about when we look at heart failure. But because it does a couple of things here, it does decrease the heart rate. And the technical term is it's a negative chronotrope, right? Chrono, time, so time is rate. So it decreases the heart rate. Decreases the contractility. So it's a little bit slower with as it contracts. And that's an inotrope, negative inotrope. And then also decreasing the rate. So it's how fast it goes through that AV node. Remember, we've got our SA, then AV, then His and Purkinje's. So how fast it goes through that AV node, it slows it down. And that's a negative dromotrope. So you can see if we had those things in the opposite, fast heart rate, fast contractility, and fast going through there, that heart is really going really, really a lot. And so how this actually works by doing all of those things, you can figure it out. Do you think that the oxygen demands of the heart muscle are going to go up or down from using a beta blocker? Anybody? Okay. I hear crickets. I don't even know if you guys are there anymore, but I'm still talking. I think you're there.
Can you repeat the
Go down.
question?
Okay, so do you think that if we're giving somebody a beta blocker that does these things, do you think that we are increasing or decreasing the oxygen demands of the heart muscle?
Decreasing.
You got it. The whole idea. So with that, we also then can get vasodilation, the alpha part. That's when we're using the carvedilol, because remember, carvedilol does both. So you can see that if you had all of those things, lower heart rate, lower contractility, lower conduction, and vasodilation, why carvedilol or Coreg is so pretty cool, right? You don't necessarily want to do all of those for everybody. And again, this is just the beta ones because they just only are doing things in the heart. Now let's look a little further. So they are used, as we said, for hypertension, but angina, right? Because what is angina? Oxygen demand is higher than delivery to the heart muscle. So you can see that we can definitely, beta blockers help in angina. Also, tachydysrhythmias, dysrhythmias that are fast, right? Because they're going through that AV node really fast, we're slowing it down. Heart failure, we want a slower thing, not this floppy thing. So it works that MI because of all that. We've got heart muscle that's died because the oxygen demands were greater than delivered. So we use beta blockers in that. And I also mentioned some other interesting ones are migraine headache, stage fright, hyperthyroidism, glaucoma, and pheochromocytoma. And that's a tumor in the kidney that makes people have super high blood pressure. So they're pretty good for a lot of stuff, but they do have some side effects we'll talk about, such as bradycardia, right? It's going to slow the heart conduct. Who's drawing? Am I going to have to stop you? Oh, thanks. But yeah, it works, I guess. We'll find out how all these work. So bradycardia, yeah, right? Remember, it's slowing it down. So the kind of catch-all number is 60. Now, more than likely, when they are ordering a beta blocker, they may already put your hold parameters. Sometimes it's 50 that they want to do the hold for. But for standard things, we'll just say anything that's 60 because that's technically a bradycardia if it's less than 60. Now, the other thing that is key to note is that people who have diabetes and they are taking an anti-diabetic medication, whether it's insulin or oral, right? You know, they don't take enough calories in, they dip into hypoglycemia, right? Well, one of the first early symptoms of hypoglycemia is tachycardia, okay? And that's when people, their heart rate goes, that's how they start feeling not so good before the sweating and, you know, change in level of consciousness. So if you got somebody who's taking something for diabetes and they are beginning to have hypoglycemia, you will not get the tachycardia because it's being blocked. So you've got to watch for people who are getting medications for diabetes. They don't rely on tachycardia to be an early warning symptom for you of hypoglycemia. You are going to have to be looking at their sensorium, looking for sweating, nervousness, and those other signs of hypoglycemia. So don't wait. If you have any questions on it, just grab an AccuCheck and see what their blood glucose level is by finger stick. The other thing is that cardiac output could get too low, right? We're doing all these things to slow that heart down, make it all this. It could go too low. And if it gets too low, we can see people starting to have shortness of breath, edema, and fatigue. And shortness of breath because you're going to get some pulmonary edema in there. So if you got somebody on a beta blocker and they're not looking so good, how do we look at cardiac output? We don't have them in the ICU. They don't have a pulmonary artery catheter. Cardiac output, the main things to look at that you're going to look at for somebody is first, are they conscious? That's a really big one. The other thing is we use their blood pressure as a proxy for cardiac output, right? So you want to grab that blood pressure if you start seeing any of these symptoms, because we could have gotten them too low for that. They could develop AV block, which again, because we're blocking that AV node, it could hold on to those signals from the atria and really not, maybe every 5 signals saying beat, beat, come through the atria, and then this one only 1 out of 5 it goes. So now their heart rate is only 20. That's not good. Again, orthostatic hypotension, that's just because they don't have that ability to adjust. They sit up and do that. And again, the other one is not so much a rebound hypertension, but a rebound tachycardia if it suddenly stopped. So again, if somebody, let's say they've had a heart attack and we're trying to really be nice to their heart and make it nice and slow and and they run out of their meds and they don't take them, they're going to be tacking away. So of course that increases those cardiac muscle myocardial demands for oxygen, and we're back in the bad zone again. So people cannot suddenly stop beta blockers. Now, beta 2, right? Those are the ones that go both places. Problem is they have beta receptors in the lungs. The beta receptors in the lungs, if they are blocked, they constrict. So that is not good for people with asthma, right? Because constriction is their problem. So you don't want to have a beta 2 blocker with people with asthma. Now, sometimes what you might find is just a very small wheezing. A lot of times docs will go ahead and give it a go, unless they have severe asthma. They may still be on a beta blocker just because it's what they need, and they give it a chance and see, are they going to have a bad time? So you can find some people that have asthma that are on a beta block, beta 2. But with that, especially if you have somebody on beta block and they've got an asthma, COPD, anything like that, you do want to listen carefully when you do your assessment to hear for any wheezes, because that may indicate that that beta blocker is really messing with their asthma and needs to be considered to be changed to something else. Again, another thing with these beta 2, aside from that tachycardia for people with hypoglycemia that we can't see, the ability for the liver, remember, liver stores glycogen, right? That gets broken down in a process called glycogenolysis to give you some glucose when your blood sugar dips. That's just the way it works. But that ability to split those and send glucose out in the face of hypoglycemia is blocked for people if they are diabetic. It just works that way. So again, people with diabetes, very careful when they're on any kind of beta blocker. Be always looking for hypoglycemia for a diabetic patient. And again, as we mentioned, the tachycardia is also masked for the patient who's taking diabetic medications. So beta blockers, diabetes, not so great. Just got to watch them carefully. Same thing with asthmas. Other little thing, because of that AV node part that's in there, you don't want somebody who's already got a heart rate of 55 to get a beta blocker, because you're going to give them a heart rate of 35, and that probably isn't conducive with a good cardiac output. So low heart rate, you're not going to give them a beta blocker. Other people that need to watch out, depression and diabetes, we mentioned already. Depression is because beta blockers slow things down, and people who are depressed and they suddenly get slowed down and they can't get an excitement out of it, right? If I'm on a beta blocker and I'm beta blockaded where my heart rate is 55 and that lion jumps in front of me, my heart rate's not going to be able to go up. I want to do it, but I'm going to feel awful because I've got the rest of these neurotransmitters pulsing through me, but I don't get the heart rate that I should, which really makes people feel awful. That's why people who are on beta blockers, exercise is very difficult and needs to be careful because they cannot raise their heart rate, right? One of those things when people are doing aerobic exercises, they watch their heart rate to see that they've reached that level. They're not going to go up. They're going to feel like total turds, really. So exercise is one of those things that's really kind of tricky for people that are taking beta blockers. And the other one that I didn't put on here is impotence. A very big problem with beta blockers and men is that it makes an erectile dysfunction issue happen. And so a lot of times people that take beta blockers, they may be on them for a while and they say, I don't want to take it anymore. I don't like the way it makes me feel. You know, I've got no sex life, or I feel depressed all the time, or I'm just so fatigued, or I want to go out for a run and I can't do it. So beta blockers, that's why they're not really first line for hypertension. They have some things, but they've been around a long time. They're inexpensive and fairly safe otherwise, as long as you stay within those things like for low heart rate and diabetes. Beta blockers are done. All right, ACE inhibitors stands for angiotensin converting enzyme inhibitors. Okie dokie, we've got that renin, angiotensin, aldosterone system that we use or make, our body has, that we do things. So what this actually does is very simply, it blocks that conversion from angiotensin 1 to angiotensin 2. And then it also prevents the breakdown of these other two substances called bradykinin and substance P. What that does by blocking this, by not having angiotensin 2 occur, we get vasodilation, mostly in the arterioles. So you gotta remember, where's an arteriole? That's that little last part before the capillary bed that feeds that tissue or organ. So we dilate there. Also helps get rid of sodium and water, right? Sodium and water go out. We do keep potassium. So of course, what are you gonna then say people on ACE inhibitors? You wanna watch their potassium doesn't go too high. Remember the intima, that inner lining of the blood vessels, that's the intima. If you got high angiotensin 2 levels, it irritates the intima very much. So by reducing that, we don't have that. And again, because remember, you want these blood vessels to be able to dilate. If they're all jacked up and not working well, because they're always getting high levels of angiotensin 2, you can get some changes in them that make them less flexible. So that's how ACE inhibitors work. We use them for hypertension, which is why we're doing it. But we also use them for CHF, and again, after people have had an MI. They are called cardioprotective. And what that is that somebody who has, let's say they've had a heart attack. You know, you've got your heart, your left ventricle is here, and more than likely you've had some injury, some part of it. But with that, you've got what's called remodeling. The shape changes, and it's not very good. Just like we can have remodeling in the airway of chronic changes from asthma, almost like we just talked about the intima, of a remodeling of the intima from, so all these negative high levels of bad things on tissues, they change. Just like, you know, like if you rub the same area, you get a callus, so to speak. It's not exactly calluses, but if you think of it, there's a change. So we want to prevent that change. And using an ACE inhibitor decreases the systemic vascular resistance, which is, let's say, your aorta and downstream. So if your heart's going to pump, if what I'm pumping against is less pressure, I now need less effort to pump out. So I'm not squeezing as hard, so I'm not remodeling, trying to pump out something that's been injured already. I hope that makes sense. So because of that, we do see people that have heart failure, they actually don't die as early. They don't do as bad if we put them on an ACE inhibitor. And I think that is one of the national patient safety goals, is people who've had an MI, unless they have a reason they shouldn't be, they should get an ACE inhibitor. So that's what we use them for, and what cardioprotective means. Most common ones is this bunch. Capitan, it's been around a million years. It was the first one. And here's the thing with it. There's a couple of little dashes after a few of these I want to take a few seconds to talk about. Is it's a short half-life, not a prodrug. So first part, short half-life. So of course that means you've got to take it multiple times. That makes it, well, not so great. But, all right, prodrug, all the others are prodrugs. Let's just say like Vasotec and Altase are prodrugs, meaning they first get taken, go to your liver, remember your liver does that metabolism thing, and then like activates it into an active drug, okay? Because they're a prodrug. It's not an actual drug yet. It needs some chemical changes to actually make it active. So something that is, hi, Stephen. So something that is not a prodrug means that if you take it and go in, it just goes through and doesn't require any activity from the liver to be effective. So if I have a patient who's got bad liver function, okay, things aren't working right in the liver, I would rather give them something that is not a prodrug, something that's an actual drug already. You know what I mean? So Capitan and lisinopril would be the ones that I would use for somebody who's got bad liver function, okay? Because it doesn't require the liver to do something to turn it into the drug. So Vasotec and Altase, those are the ones that I can't really have the effect if they have a liver issue. There's also one, and many of the antihypertensives they're coming out with and redoing, and they've been doing it for years, is they're combining them with a diuretic. Because for treatment of hypertension, the first primary thing that everybody does is give them a diuretic first. See how that does. Get rid of fluid, see if that decreases the pressure, and maybe we're good. They've come up with one that's lisinopril with hydrochlorothiazide, and that's Zestoretic, is the combination there for you to know about. Again, ACE inhibitors similar to the alpha blockers that first dose orthostatic hypotension. And it's something weird about just the first dose, not every single one after that, but it's the first dose. You'll find something also called the ACE cough. So if you get somebody that has got a dry, hacking cough, it's like they're not productive, they're not sick, they don't have bronchitis, they don't have COVID, they're just coughing, look and see, are they on an ACE inhibitor? Because again, as we said, ACE inhibitors prevent the breakdown of bradykinin, which is, got the word, but what it is that buildup of bradykinin is what is contributing to the cough. And the crazy thing is that, you know, you'd expect a side effect to happen like right away. Well, people can be on an ACE inhibitor for like a couple of years and then develop the cough. So it doesn't have to be right away. It could be that somebody's been on it for years and it never caused it. And now they're starting a cough. You look and they're on an ACE, they're like, I've been on this medication for 10 years. The cough just started a year ago or 6 months ago. Probably is still the ACE inhibitor. So the docs probably do need to get rid of it. Now, as we mentioned, ACE inhibitors, they get rid of sodium and water, but they keep potassium. So as we said, you got to worry, look out for high potassium levels. It can happen. Some people can get a rash. Now that's one of those things, if they get right away, you're going to see it. But angioedema, that's where people look like their entire mouth is all swollen. And problem is that it's goes into their larynx. So they end up with laryngeal edema, and then they need to be intubated. I mean, this is off the charts bad. That is not something that's going to happen like 2 years later. That's going to be like, you're going to see it there and know it. And then they're not going to take that again. Rarely you'll see people, you know, their white blood cell count take a hit, but that's not very common. And I wouldn't you have to worry about that one too much, but it is in the background.
Miss Jimenez,
Yes, ma'am.
going back to the cough, is that like all the time they're kind of coughing, or could it be triggered when after they're done eating maybe?
No, it's just a cough. I mean, it's going to be like all the time.
Is it like a hard cough, or like they're clearing their throat cough?
No, like a dry hacking cough, just as if I was going to be, you know, like they got a tickle in their throat that but they can't help it. It's just, you know, but I can't even make a good one right now. Thank goodness. I think I'm COVID clear.
Thank you.
But, you know, but not one of those, you know, that's something different. This is just a hacking, annoying cough. And like, I actually had a young guy that I seen one time and just trying to interview him and whatever his complaints were, he kept coughing. And I was like, do you not notice that you've coughed like 40 times in 10 minutes? So sometimes they don't realize it because it just slowly becomes just part of their life and they don't know that it has to do with that medication. So you might notice that and then take a look and see what meds are they on. Again, that's why when you're in clinicals as a student, which is not happening now, but you don't care just what they're getting during your shift. Everything that's been in them is inside their body. So you got to know everything they've been on because that's what symptoms or issues you'd be looking for. Yeah, so the cough's just kind of a dry, annoying cough. But it is probably the most common reason why people get off of ACE inhibitors because a fair amount do get it. But people who should not take an ACE inhibitor, if you're pregnant, if you've already had the angio, I mean, if you blow up, you know, swell up like the girl from, what is it? Charlie and the Chocolate Factory, you know, you're not going to take the drug again. Okay. So don't do that. If somebody already has an elevated potassium, they should not be starting on getting an ACE inhibitor because again, it's going to keep potassium and get rid of sodium and water. So you would throw them into super high potassium levels. So they would not be somebody who you would get an ACE inhibitor. So if you've got a patient who's got really high potassium, maybe they're renal failure, and they've got high blood pressure, and somebody orders an ACE inhibitor, I'd be like, hey, wait a minute, their potassium is this. Now, nobody's ever gonna ignore, even over 4.5, nobody's gonna ignore it. They'll be on it, I hope. So just know that elevated potassium is not good because it does help bring potassium stay in. Again, if women are lactating, then it means it goes to the babies, which is not good, and to kids, as well as to bilateral artery stenosis. Again, because of how it works with the sodium in the water and bringing in potassium, you don't get enough flow into those kidneys. So ACE inhibitors are not something for with bilateral artery stenosis, which many times is seen in hypertension, though. Not that much, though, but it is seen. So if you're giving somebody an ACE inhibitor, look out for hypotension, right? We don't want to overshoot. That's probably overshoot all the time because you have no idea how somebody's going to respond. And again, watch out for that cough. It's very, very, very common. ARBs, they're very similar to ACE inhibitors.
Nanas,
Yes, ma'am.
I have a good question about the ACE inhibitors.
Okay.
For exam purposes, do we need to remember like any specific levels as far as the potassium? Like the book says something about 5. Oh, you have it there, yeah. Do we have to remember? Okay.
I would think so, yeah.
Never mind.
I mean, you might have, if you had a question, who would you not give it to? Somebody with potassium of 5, a potassium of 3, a potassium of 2, 1, you pick the high one.
Right, but I mean, like, are you going to put like a 6 or like a close number like that? It's going to be kind of tricky. You know what I mean?
No, I mean, look, if somebody has a potassium of 6, nobody's worrying about an ACE inhibitor at that point.
Right.
There's another crisis going on that would be just like making a weird question for something that doesn't exist in life. If you got somebody with a potassium of 6, you're going to be doing a whole bunch of other stuff than worrying about an ACE inhibitor in there. I mean, they should definitely get it, not give it for sure. But there's another crisis going on. And that wouldn't be like a normal thing, but
I get it. So, I forgot you made good questions. That is just, I was thinking about other professors. Thank you though.
Yeah. Okay. All right. Okay. ARBs. All right. So remember, ACE inhibitors prevent angiotensin 1 to becoming angiotensin 2. ARBs, they actually prevent angiotensin 2 to bind, okay, to any of those type 1 angiotensin 2 receptors. It's very technical, but what you just need to know is that it blocks the binding of angiotensin 2. So your body has already made angiotensin 1 turn into angiotensin 2, but now it just can't bind, okay? And this works on that vascular smooth muscle. So again, if it's blocked, they can't constrict. So it keeps you nice and dilated. It also then prevents the secretion of aldosterone. so that it actually helps you with being able to clear water and sodium. But again, similar to the ACE, get rid of sodium and water, but you keep the potassium. So you gotta watch out. Again, potassium's back again. ARBs, like we talked about, we use them for hypertension. They're used for a whole bunch of other stuff there. Nice, cool, weird thing that they do delay diabetic problems with their kidneys. Because again, kidneys get destroyed from people with diabetes as well as a million other parts. So if somebody's a diabetic, right, you were looking for a good blood pressure medication, ARB is way better choice than a beta blocker, right? Because it doesn't do anything to block my symptoms of hypoglycemia, and it may help delay the kidney from going down the wrong track because of diabetes. So ARBs are pretty cool. And the most common ones you'll see are these, losartan, which is Cozar, valsartan, which is Diovan, and irbesartan, which is Avapro. There's a whole bunch more, but pretty much those. So the ARBs are Artans, right? Artans, A-R-T-A-N. But things to note, can still do a little bit of this angioedema on them. There is significant fetal injury if people are taking it in the second and third trimester. So we just say completely contraindicated for people that are pregnant. Again, if people have renal stenosis and if they are lactating, and again, if they know they have an allergy to anything, right? So pretty much no pregnancy people should have this, no renal stenosis. So that's very common between the ACE inhibitors and the ARBs. That's it, okay? Vasodilators. Hey, that sounds like the way to go, doesn't it? You know, directly, ooh, let's just make those blood vessels dilate. Just go straight for them peripherally. All those things out here. Sounds great. You know, I decrease my systemic vascular resistance. So of course, you got to worry, am I going to drop my blood pressure too much? And these medications are really powerful, which is apresilene, which is hydralazine, and nitroprusside or nipride. Difference between the two is that apresilene, which you can even have as a pill, is just arterials. But nipride is both arterial and venous. So that's like huge dilation. It's only IV drip. We use it for hypertensive crisis in the ICU. I'm not getting into that. You will not get like crazy on this. Just know basic what it does, because a lot of the detail of dosing and monitoring and stuff like that you'll be doing in your AB1 level classes. But we do need to mention it here because these are really potent vasodilators. People who cannot get these, they've already got low blood pressure, right? It's called killing them. They've got cerebral edema, basically all head injury stuff. They've just had a big MI. They have heart failure sometimes, because we don't want everything to dilate so much that you can't even focus getting any return, right? Because you dilate, you need blood to come back to the heart to pump out. But if everything's so dilated, not enough is even coming back in, we can make some MI things pretty bad. So those are your contraindications for vasodilators. Hypertensive crisis. Here's a whole bunch of information. All you need to know is that nipride is both arteries and veins. It gives rapid reduction. Interesting thing, again, it can really give you blood pressure just tank. So you got an IV, you know, you're gonna have to like stop it for a few moments, let the blood pressure come back up if you overshoot it. There is this slight possibility of cyanide poisoning through the medication, which is thiocyanate toxicity. And you can see all of these little things. Don't worry about it. Just know it can happen. And it's after people are on it for several days at high doses. I've given nipride a million times. I've never had anybody with any kind of cyanide type poisoning from thiocyanate, okay? But the IV and tubing are ones that are covered in that little like brown plastic covering. So this is just really know it exists, kind of that it works really fast. That's about it. Again, interesting factoid. Again, the poisoning is interesting. Happens at high doses for a long time. It's a really short half-life, right? That's why we have to give it IV drip. We can't just give it to them and then let it work for 6 hours. It's going to be continuous. So that's why if you've overshot them, you can stop it. And then, in a couple of minutes, they're going to come back and not have that response. But again, you got to really watch out for hypotension if you're ever giving it. Something you might see a whole bunch more are calcium channel blockers. And they're broken into a couple of different ways. These are just the whole big chunk of names of them. Cardizem, I'm sure you guys have heard about. Norvasc and verapamil are probably some of the more common ones that you'd see. We've got peripherally acting and centrally acting, okay? Peripherally, it's like nifedipine, and that just works directly on your peripheral blood vessels, so just dilates them, and also coronary arteries. Centrally acting, verapamil and diltiazem, or cardizem is what diltiazem, it actually blocks those blood vessels, but also directly inside the heart. It goes after the SA node. Remember, the SA node is the first one. So that's going to decrease your heart rate. It also decreases the contractility. And if anybody remember what it meant for contractility? If it decreases it, there's a word that we had before for the beta blockers.
Does that have to do with the oxygen demand? What decreases
It works kind of the same way, but there's a word. So if something decreases contractility, it is
Inotropic.
What's that?
Inotropic.
Yeah, so it's a negative inotrope because it decreases it, okay? So you got to always remember, are you upping or downing? So it's going to be a positive or a negative. So we're making it down, so it's a negative inotrope, okay? And when I say all on here, that means both peripheral and centrally acting. So all the calcium channel blockers can be used for hypertension. All of them can be used for angina, but only verapamil, those two central ones that work on that SA node, are used for atrial fibrillation, atrial flutter, and supraventricular tachycardia. Okay? So that's kind of an important slide. So peripherally acting, which is ones everybody's taken for hypertension, you've got to worry about what's called reflex tachycardia. So again, remember, our body is all this checks and balances. If I dilate everything, my monitors are going to say, hey, where blood pressure is going low, how can we make it go back up? How can I get my cardiac output up? I can raise my heart rate. So some people, when it dilates them out, they end up getting tachycardic. So you've got to watch for those, as well as we've got dilation. What happens, all those little pores in our blood vessels open, especially in their legs, so they can get some peripheral edema. So that's what you'll see with those peripheral. The centrally acting ones, which is cardizem, verapamil, orthostatic hypotension, peripheral edema, bradycardia, right? We're SA node. Constipation, it just slows, it's just a thing, it slows everything down. But also because we're blocking that, we can actually get that wide QRS or QT prolongation. So those are ones that are a little bit more tricky to watch. And again, we are using the centrally acting ones really for AFib, A-flutter, and SVT. And kind of that's what we want to do. We want to widen that out a little bit. So that's when we get a little bit beyond, we've overshot when we start getting into those wide QRS or QT prolongations. So people who cannot get nifedipine, acute MI, unstable angina, aortic stenosis, intestinal obstruction. All right, it's just a list, not too hard to think about. Verapamil, again, big SA node is blocked, so we don't want to have anybody who's got heart block, or if they got digitoxicity, because again, digitoxicity has these funny rhythms to them, which we didn't get to yet, but we will. Severe heart failure, and also if they're lactating, they cannot have verapamil because they don't want that to go to baby. So again, because we've got these, sometimes we combine medications. So especially if you get somebody on a calcium channel blocker and a beta blocker, whew, you really got to watch that heart rate. You're going to really expect it to come down. That's somebody who maybe they've been sitting there tacking at 105, but that is killing their heart. They just can't deliver the oxygen for their heart to beat that fast. They want to slow that heart down and get it where it's more effective beats and less oxygen demand and less rate. So they'll combine calcium channel blocker and beta blocker. So they keep a heart rate of about 62 or something. So you always want to be making sure that we're not getting down into the 42s. Here's one of these ones. Grapefruit juice, calcium channel blocker, toxic levels of your calcium channel blocker. So here's one, grapefruit juice, no calcium channel blockers. They do not go together. Also, if you take digoxin at the same time, you can have higher levels of digoxin if you're taking one of those central acting calcium channel blockers. I'm trying to whip through this so that this thing doesn't stop on us. Then there's these other direct renin inhibitors, remember? Angiotensin 1, angiotensin 2, renin, aldosterone. So this is actually going directly after renin. Problem, angioedema happens. They get high potassium. If you give them a whole bunch, they can end up having a lot of diarrhea. Also, people with asthma, they tend to have more chances of getting this angioedema. But also, they cannot have a high-fat meal near when they're taking these because it does interfere with absorption. So somebody who just loves McDonald's or whatever they're eating and they take their medication, but their blood pressure is still sky high, well, maybe it's because you're taking it at the same time you're eating your McDonald's. Don't do that so that you can actually get the absorption. The most common one is this Tecturna. It actually binds with renin, so it prevents angiotensin 1 to even become around, right? We need angiotensin 1 to become angiotensin 2. So we just never form angiotensin 1 because it binds that renin. So we end up with lower angiotensin 2 and lower aldosterone. And we definitely use this for blood pressure. That's it. I don't know how to get out of that. Okay. So I'm going to get rid of that and see if people got some questions. Ooh, like corona cough. Yes, exactly. I'm seeing these things. Now I can see these questions, okay? Oh, now I see what it's about. Oh, that's the question thing. All right, you guys can unmute yourselves if you want and pop in if you got some questions on this here specifically. So this today was hypertension. I do have after this one, I've got another, I'm making them into shorter ones so they're not 2-3 hours long, which will make people nuts. We'll separately do the diuretics. We will separately do things for heart failure and for rhythm disturbances. So we'll have like 4 different ones that I've got pretty much made. And I want to find out from you guys, do you want to do them again like live Zoom and then recorded? Or do you just want me to record them and then you can just see them on your own? What do you guys think works for you?
Live Zoom and you record.
Yes.
Just do,
Yes.
just do the record and try to find a way to post it in a nice way.
No, live Zoom.
Live Zoom.
Oh, live Zoom, live Zoom.
Yeah,
Yes.
and then record it and then post it.
Yes.
Okay, so do
Live.
live, but record it and post it, which is
Can
what
Yes.
we also have the PowerPoints at the same time so we can make notes in it, please? Like at the same time?
Okay,
as
yes, I can do that. I was thinking about it, but I made a couple changes right before we started. So I will do that because I can post the PowerPoint separately because they are made separately. So I can definitely do that.
Thank you.
So any other, I mean, this is by breaking it down and see how that was like a bazillion meds, right? But those are the ones that are really important to get because so many of them are used also for heart failure, for rhythm disturbances. So if we've already got them and really know these meds, you'll know already 80% of the rest of them that we're going to talk about for the other topics because you'll find them repeatedly. As you notice, when we looked at the indications, a lot of them had heart failure, post-MI on them in addition to hypertension, okay? Which is what we're doing today.
The repetition helps me.
Well, good. So yeah, because I had posted, I think, a PowerPoint that I had used yesterday and or last semester, and what do you call it? It's there, but it's in a weird order. So, but I'll post this one, and then I will also post the other ones. And then, so when do you guys want to do another live? Because we need to find a way that what we do as far as class is that we're actually taking care of the 3 hours of class that we were supposed to have, right? So we need 3 hours of activity. It doesn't mean 3 hours face-to-face Zoom necessarily, but it could be with additional worksheets or Zoom stuff or.
No additional worksheets, please. No.
Please, no other worksheets.
Okay,
Please.
that's fine. I'll take that.
I'd rather be in here for 3 hours than get another worksheet.
I have a quick question.
Yes.
So the PowerPoint for the cardiovascular drugs that you posted from last semester, do we just disregard that and use the ones that
Still
you
good information. Oh no, I wouldn't. I mean, disregard it. I mean, why would you disregard it? I mean, that's great information. It's just that I didn't deliver it in the same way. The information is still good. It's got a whole bunch of everything thrown in together, which may help you when you go to review for exams or stuff. But yeah, I wouldn't throw anything disregard. That would be probably not a good.
I would really appreciate us having Zoom when we're supposed to be in class. When we would normally be in class, this is great.
This works really good. Yes.
Yes, I have no life right now, so I'm good with this.
I didn't want to do Zoom for 3 hours. I think that's going to be a little much. What I was also thinking of doing is doing an open Zoom like office hours or question period time, where I can be on Zoom and you can pop in and then know that I will be here for that time, that you can then ask a question or not, and then close it out for if people wanted to participate. I don't know if what you guys think about that. Anything?
Well, I like the structure. So meeting you here on Zoom and having class and then being able to go back and look at it again helps me.
Okay. So what I can do, if you guys want, because what I want to do is try to end this one, and then I'll figure out how to, post it, and then I can do another. We can just take a little break if you want, and then I can come back and do the next one. And if you got other things to do, you don't have to pop back in. You can just wait for the recording. But again, like I said, we are expected to get our time of your instruction or interaction to equate to the 3-hour credit you're supposed to be in class. We got to do it somehow.
So could you set up a specific topic at a certain time, like one topic at 8:30 and one topic at 9:30, one topic at 10:30, and then satisfy those 3 hours?
Yes, I could. I just don't know how many people want to do it that way, but at least I think we have the opportunity. Again, if I can record each of them and do it, that's fine, and people will do that. But I think I'll do that. Yeah. So what I'm gonna do is, okay, I'm reading your stuff today with all your work and so. Okay, yeah. Here's another a question about ATI exam. Last I understand, we are not going to do the huge, big, single ATI exam. We are going to allow you guys to do the 2 practice exams that are inside ATI. One is going to be due April 19th, which is a Sunday night. The other one is going to be due April 26th, which is a Sunday night. So you do 2 practice exams. The higher of the 2 will be your grade. And I'm not sure about that. I mean, there's a scoring list based on the level, which I have a copy of that I think Dr. M may have already shared with you guys from the other class. But it's a consistent thing. It's a scale, but we fixed it so that nobody gets as bad scores and points like they used to.
Can we take the practice exams one time or repeatedly to get the score we want?
If you can take them repeatedly. However, the last
score is the score that stays.
Yeah, but for that time, you know what I mean? So you could start now. You could start doing it, bang, 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 bang. Maybe you get 100 today. Stop, just let that one submit. Or you could say, oh, I want to keep going. I want to go. I'm a level 2. I know I can get to a level 1. You can keep trying. And then let's say you do hit level 1 or level 2, let's say, and then you still have a couple of days. You could try it again. Maybe you'll get a lower score. Well, then do it again. Once you think you've got the score you like, then stop for one, because it will be the most recent one.
Okay, so it's still going to use the scale that's in the syllabus, not like if I make a 98, I'm going to get 100 as my grade.
Yeah.
Okay.
There's a little tweak to the thing that I have the copy of. I have to post because I'm waiting for this whole week to just get through and see what people are going to do. Well, here was a question about the ACE inhibitors. The prodrugs beneficial for the liver, or was it the opposite? Does anybody have an answer for that?
the non-pro is better if they have liver problems.
Correct, because a pro drug, just to think it's a prototype drug. It's not really the whole drug. It needs the liver to do it. So a pro drug is a prototype drug, needs the liver to make it active. If you got a bad liver, it's not going to make it active very well. So you want to take an actual drug, not a pro drug. Okay. That's specific to those.
Question.
Yes.
Our Module C exam is still on the 14th, right?
As far as I know. Yes. Not changing exam days, I don't think. No.
Okay. Just double checking.
Yeah, that's okay. All right. Let's see. Yes, graded by levels on the ATI. It does levels. Drug cards, I will take them through this afternoon. Just fan them out, take a picture. Pretty easy for that. I have to take a look at my thing to see exactly what our topics are for this. I don't even know if this thing is still recording, to tell you the truth. Because it's
It is.
It is? Okay, good. Because I put a time on the meeting, and I don't know if it kicks you out when your time is or not. Okay, so the cardiovascular drugs, if you guys were looking on your syllabus or reading list, everything that we have for week 11 and week 12 are going to be module C. The psychotherapeutic drugs, I'm going to push those down because we don't have enough time, I don't think, to do them. What's today? Today's the 31st, right?
Right.
And then we just have next week, and then the following week is the exam again, right?
Correct.
So I think with 2 weeks of instruction, I don't want to do more than just cardiovascular. Okay. So I'm going to push out the everything that was in number 13. So it's everything that was in week 11 and week 12 will be module C. So it's all of the cardiovascular, antihypertensive, anti-anginal, heart failure, anti-lipemics, diuretics, coagulation modifying, and antidysrhythmics.
So are we just gonna move the psych drugs to after?
I'm going to push them down into that last bit so that we actually have some time. The final exam is May 5th for this class. So we actually on that previous week, I think I gotta have a calendar here. There's too much stuff for this one class, I'll tell you. Don't you agree?
Yeah.
So right now, we are, sorry. We are here on the 31st, right? We do here and here are cardiovascular. We are going to, that's what we're gonna do, is the week of, so your module C exam, it's gonna be on the 14th. We're gonna start the content for psychotherapeutic that week. Like we're not blowing the whole week off, you know. I'll still put some content in there. And then the following week is when we can do endocrine, immune, and then that, yeah. So we are just gonna be pushing the psychotherapy drugs to fall within that week of the exam because we need to have 3 hours of content, not just an exam for the week. Especially when we're online because we can put it anytime we want, right? All right, so let me see whatever, let me see. Yes, I'll open the psych drugs assignment today. So you can do whatever you want. Some of the conditions for heart have multiple drugs used to assist with symptoms. AFib gets beta blockers, calcium channel blood thinner. Is there a priority? Yeah, but don't worry. No, we're not gonna I'm not going to try to make you guys into prescribers, okay? Because that'll make you nuts at this point. So yeah, GI psychotropics will be in Module D. And so that new content will count for 50% of the exam, or 60% of the exam, and then the other 40% will be from the previous modules. Okay. So what I'm going to do is I'm going to see if I can stop recording and do this, and then set it up for about, and let's say in 15 minutes or so. And
I have a question.
Yes.
When is the blueprint going to be posted?
I should be able to have the blueprint for you guys for this.
Actually, Miss Jimenez,
maybe by the end of this week, I think.
Miss Jimenez, could you just make a video like you did at the end of our last class, like when you kind of went over like the big points like you did for the blueprint, because that really helped.
That was helpful, yes.
Yeah, could we do like a little Zoom of like a Q&A with the blueprint? That would be absolutely amazing.
Yeah, that's fine.
Okay, cool.
Yeah, I can set up a date for us to do a review. I'm gonna call it, just open question forum, let's say, and you guys, whatever your question, but you have to have a specific question. I'm not gonna, like, please reteach that. Come up with a question so I know you, like, these are good questions you guys have here that I can't keep reading. So, do you go ahead and submit this? Yes. Can I ask about previous tests? Okay, what do you want to know?
I'm not really sure what happened, Professor, but I have never skipped a question, and I think everybody else can agree with that. It won't let you skip a question and go to the next question on the Canvas, so I'm not sure what happened with that.
I can't tell. I tell you, it is the most bizarre thing I've ever seen.
Yeah.
Unanswered. It was.
It won't even let you go to the next
thing next to it, and look, it said unanswered. And I was like, what?
Are we getting counted off for that question?
Sorry?
Are we getting counted off for that question?
Yes.
Can you say what the topic was so we can
hang on. Those of you who popped in late to know, yesterday I spent 6 hours. I went every single person's every single answer, because this thing minuses off for select all the applies and stuff. So it gave people, like, maybe they get a 0 if they pick 2 of the 3 correct. They didn't get all 3, or they picked 2 correct and 1 wrong one. It gave them 0. So like, that can't work. So I had to go back and individually score those. And that's when I saw it. It said unanswered. So that's just one for there. But there's a whole bunch of other ones that I got really flexible on. So I would say there's probably about 6 to 8 points that I was very flexible on that were like grace to you guys. So the skipped question, I can't answer. I have no idea. I just know it was weird. And I've never seen anything where everybody didn't answer a question, and it should give you, like I said, a prevention from being able to do it. But I think I guess you can pass through it. I don't know. So anyway, so hopefully you guys did see your scores did go up yesterday evening from my adjustments to them. So anything else? Okay. So what I will do is I'm gonna let us end this meeting, and then I'm gonna figure out how to record it and stick it inside the modules, and then we'll open up a new Zoom. Send you out a new one for 11:30. That I will start with the diuretics, I think, and then also record that. If not everybody can stay on, that's fine. Because I don't want us to sit here for 3 hours today doing this. We didn't start at 8 either. Because I wanted to get to touch base with you guys and see how things are going. Can you know the subject? I don't know what you mean. Can we know the topics?
Can we know what that question that all of us skipped was over?
Oh, it was the medications for VRE.
I answered that one.
I did too. It was a select all that apply.
Yeah.
And
Yeah,
I believe it had like the line of
Okay, so what I'll do is I can go back again and I will add 2 points to everybody, okay? So whatever you got 2 more points. So we can move on because I just cannot, I have been living with this test for 3 whole weeks, 4 weeks, nonstop. And then we've got to move on with content. Okay? So that way, hopefully you guys will feel that the grade you will get with the 2 points more is the appropriate grade that you earned. Because that's, I mean, I say I want every single one of them to be sure nobody got marked down for things when they had correct answers. Is that okay?
Thank you. I appreciate your time. Thank you so much.
All right, so I'm going to do that. I'll post this one. I'll post the diuretic, and then I will pull this up and shoot you out what the whatever the code is to get into the one for 11:30. Is that okay? You guys are all so quiet now.
Thank you for
Thank you.
Yeah, I'll tell you.
Thank you.
We don't use it's a pain. But.
Thank you. Thank
All right,
you.
I'm gonna hit
We're
stop recording. And then, sorry?
Thank you.
Oh, you're
Yes.
welcome.
Thank you.
All right, so you can click off and we will stop recording and then we'll go from there, okay? See you later.